This program is brought to you by Emory University.
All right, good morning, everyone. Welcome to the first cardiovascular grand rounds of the season. Appreciate everyone coming. Today, we have Dr. Chandan Devireddy as our speaker. Most of you know Chandan. He's a associate professor of medicine and one of our very talented interventionalists who works primarily at EUHM. Chandan's had a long interest in renal denervation, as I think presented one of the more balanced pictures of this throughout the evolution, and it's certainly been in a very interesting area with a lot of hype and, you know, it was going to cure everything, and then sort of a not so exciting multi-center trial, and then there's been a lot of controversy about that trial. And the technology has evolved, so I'm looking forward to hearing an update from Chandan and help you will clarify all of this for us. Chandan.
Thanks, Bob. Good morning, everybody. It's an honor to kick off the season here for Grand Rounds. I'll go through quickly. Sorry, my apologies for starting late. These are my disclosure slides. So the objectives of today's talk is to understand the mechanism and the relationship with the sympathetic nervous system and the pathophysiology of hypertension. Go into a little bit of nuts and bolts of the HTN-3 trial, which Dr. Taylor had mentioned, and to talk about some of the limitations and potential problems that trial encountered and how it was designed and implemented. And then go through some novel studies and ideas of other ways to affect the sympathetic nervous system to try to lower blood pressure and possibly modulate other disease conditions. So hypertension is still an enormous problem, and this is clearly evident for those that are taking care of patients with cardiovascular disease or even patients without cardiovascular disease who are on their way these days. As far as overall burden of health, hypertension is felt to be one of the precursors to a number of conditions, including coronary disease, heart failure, and stroke. It's estimated that by 2025, 1.6 billion people may have the diagnosis of hypertension as a label to their health conditions, and this will place an enormous burden and strain on the entire global population as far as health promotion and disease prevention is concerned. So this slide is likely obvious and pretty common sense to everyone with medical training, but our primary goal in the therapy of hypertension is really to affect this stage of hypertension. This is something that we cannot do with potentially medications or any catheter-based procedures. This is something that likely that the biggest bang for our buck is in education, in promotion of exercise and other healthy habits. But that, of course, has been a challenge both here and across the world as a Western lifestyle and sedentary lifestyle takes hold of people in the way we work and live today. But for those patients who have established hypertension, what we're trying to do is prevent this cascade of disease, which eventually takes us along the pathway to dialysis, congestive heart failure and cardiomyopathy, stroke and coronary disease, which again hastens the incidence of our final common pathway here, which is death. What we do know from data, and even some interesting data described just at the end of last week, that even small reductions in blood pressure can lead to tremendous benefits in reduction of cardiovascular mortality. So if we, based on this meta-analysis published in The Lancet a couple of years back, if we can just drop the blood pressure by 2 points, then we're looking at 10%, 7% reductions in the incidence of hard events, cardiovascular morbidity and stroke mortality. If we could do that, it'd be great, but the problem is we find that this is a challenge for us to do in our patients that we see in clinic. Our patients will come in and tell us, okay, I'm going to take your meds, I'm going to measure my blood pressure every day, and I'm sure most of you can recount tales of patients coming back 3 months later, 6 months later, who really haven't done anything that we've advised them to do. In terms of our ability to record the burden of blood pressure, historically, the office-based blood pressure has been the way that we've done this, and we've now, over the past decade, have realized that there are significant limitations in just measuring blood pressure in this way. So what we're doing essentially, as our patients deal with parking and I-75, 85 connector traffic and looking at us in white coats that really freaks them out, we have a blood pressure that's significantly elevated, potentially, that from what is truly taking place when they're just at home or in their workplace, dealing with their comfort zone. So again, high variability, but what we've gathered further understanding is that by measuring the blood pressure over a 24-hour period, we get at least a better understanding, may still be somewhat relevant to certain confounders, but we get a more complete 24-hour recording both at day and at night to determine the true burden of blood pressure. And that data can then additionally stratify these patients based on their daytime and nighttime blood pressures as dippers or non-dippers, when the blood pressure is normally supposed to drop slightly at nighttime, which can potentially identify patients at even further cardiovascular risk. So if we can get that type of data, we find that it is much more predictive of patients that have cardiovascular outcomes in the future. So if we look at clinic outpatient blood pressures, along the spectrum of blood pressure as it elevates, there's just a very flat curve in terms of our ability to identify cardiovascular morbidity, but the same degree of elevation in a 24-hour ambulatory blood pressure monitor truly separates these patients from a low 5-year risk of cardiovascular morbidity to a much higher one at a higher level of blood pressure in a 24-hour measurement. And this study kind of shows this type of idea in a different way. So independent of the outpatient ambulatory blood pressure in the office, whether or not there's a low or a high blood pressure in the office, if you get a 24-hour ambulatory blood pressure monitor measurement, whatever the value is in the 24-hour monitor is much more informative and predictive of the patient's true burden of blood pressure. So patients with a low blood pressure in the clinic, those patients who had a high value on their monitor have a much higher incidence of cardiovascular events. Same thing with patients with a high blood pressure in the office, a low monitor really puts them in a much lower risk category. And this may seem straightforward, but it's really not a test that many of us do very frequently, despite the power in its recordings and information for the patient. So this is just another way to look at this data. This is kind of some of the data with population-based blood pressure with NHANES kind of dissected out in a different way that we're doing an okay job over the years, this is over the last 20 years, looking at how we're able to identify patients in terms of the prevalence of blood pressure, but our ability to control has sort of reached a plateau and now is kind of dropping off again. So we have to think about the reasons for why this is and ways that we can potentially do this better. And this is, I think, very relevant based on some news that was published in the lay press on Friday. So are many of you familiar with the SPRINT trial? Does this at all sound familiar? So I actually was out of town this weekend and didn't hear about this until later this weekend. But essentially what this was, a very large trial sponsored by the NIH, not a pharmaceutical sponsored trial. Now, I will preface this with the fact that this is not the actual results that have been published. It was just an announcement in the press by the sponsors of the trial. But it was a very powerful trial in terms of its methodology from what we can tell so far. Again, this has not been published in its full details, but this was over 9,000 hypertensive patients over the age of 50 with at least one cardiovascular risk factor. And the idea that was being tested in this trial is that if we can get blood pressure to an even lower value below what is currently advocated in the guidelines, and our guidelines have been really wishy-washy in the past 2 years, and that some folks have even said, well, maybe we need to go higher in higher age populations. But what they did was take these patients and randomize them to a blood pressure control of 140 or blood pressure control of less than 120. And at least from what they're telling us so far, this trial has now been terminated just a few years into its enrollment because there was a clear signal that there was a mortality benefit. So this broke a lot of... Which one was the mortality? Oh, I'm sorry, the mortality benefit was in the patients who had a blood pressure lower than 120. I assumed that, but I wasn't. No, that's a good question. Now to get to that point, at least from what they've told us so far, the patients in the group with a blood pressure of less than 120 are on average of 3 medications, which is a lot of medications if you think about this. Now this trial did not include diabetics, did not include patients with chronic kidney disease, and it still awaits peer review for final publication, but it's just a little taste of what we might expect to see later this year and how this would dramatically change our guidelines for how we can treat patients with blood pressure. So in my mind, this is a really big deal, and it's NIH data, so something to think about, and also to sort of flavor a little bit of what I'm going to talk to you about for the rest of this. Now, along those lines, if patients are having to take 3 medications to get their blood pressure that low, this was kind of an interesting analysis and something to kind of take with a grain of salt. But this was a survey done in CIRC Cardiovascular Outcomes asking folks how many weeks or years of their life would they give up to not have to take medicine. Now, the majority of the patients said, hey, medicines are helping me, they're going to save my life, I'm going to stick with this. But 30% of patients were willing to give up at least some part of their lifespan not to take medicines. And I'm not saying this to say that, well, we should stop giving patients medicines, but just to kind of give a sense of what's going on in our patients' minds, that at least a quarter, if not more, really don't like us when we tell them that they have to take medicines. There's kind of an adversarial relationship that develops in some ways. And some of this just has to be education, and we can do a better job of that. But some of this is also compliance. So for whatever reason, and I'll go through some of these, we have some patients that just cannot stick with the plan. And by not sticking with the plan, it has a significant impact on their outcomes long term. So if you look at this in the green line, these are patients that were fully adherent over 80% of the time. Their incidence of cardiovascular events was low compared to those patients who were compliant only 40% of the time or less. That makes sense, on its most simplistic base, but despite this knowledge, we still are not doing a good job in making an impact in these patients. So what types of things impact compliance? Well, the patients who are most compliant tend to have high degrees of social support and tend to have insurance coverage. Again, that kind of makes sense. Those patients who are non-compliant typically are younger. Some of this may have to do with the concept of this feeling of invincibility. I'm only 30 years old. Doc says I need to take medicines. Well, what does he know? I feel great. Patients who have some type of psychosocial or psychological disease, psychiatric disease, which make it difficult to take medications. But here is an interesting one, is the complexity of therapy. The more pills we give our patients, the more side effects that they have a significant impact on patients' ability to comply with what we advise them to do. And we see this every day in our clinics. Now, this was an interesting trial published just 2 years back, which looked at patients who were referred for treatment of significant resistant hypertension. Patients, there's definitely a selection bias in this, and that these patients had failed whatever advice was given to them by their primary providers. Now, these patients had testing done in their urine to actually look at whether they were taking their meds. Once they were, had an intake done by these hypertension specialists, were given a significant change in their regimen and told to comply with this, nearly half of the patients became non-compliant in some way to their medications within a year of starting therapy. And again, these are patients that were referred to these providers specifically because their hypertension was that bad. You'd think there might be some additional emotional investment on these patients to try to stick with the plan, but sometimes it's actually the opposite. Some of these patients are not gaining our goal therapy because they're non-compliant in the first place. And 15% of the patients in this study were on nothing. Told their providers up and down, oh, yeah, I'm taking the medicines, it's all going great. And in essence, you don't want to say that they were fibbing, but it's a little bit more complex than that. Some of it is a little bit of a guilt complex where patients feel badly to tell us that they're not taking their medications. And it's a very interesting dynamic between patients and physicians. You could have a whole grand rounds just on that. But the bottom line is a lot of patients just don't take medications, no matter how hard we try. So our medications are our only option, and this is sort of my segue into the rest of the talk. But medications work great. It is the established mainstay of therapy, and I doubt that it's going to change anytime in the future. And we can do a lot of great and powerful things with medications if we can get our patients to take them. But our real-world experience and data, as I've just shown, has demonstrated there is a significant proportion of our patient population that, for whatever reason, we cannot impact. And there are patients that take their medicines and still can't get the goal of blood pressure control that we'd like them to. So in kind of going back to this message that's being hinted at from the SPRINT trial, if we can get blood pressure down in more patients to a lower level than what we're doing now, can we potentially impact our health system to both improve patient outcomes and potentially lower the cost and the burden of what happens to these patients 10, 20, 30 years down the line from their cardiovascular morbidity. So with that, I'm going to kind of shift gears a little bit and just go through a little bit of an overview of the sympathetic nervous system and how it relates to the hypertension pathophysiologic process. So the autonomic nervous system is essentially what I describe to patients as the body's thermostat, and it's pretty much common sense knowledge from all of you that have taken basic physiology classes in med school. And we think about it in its simplest terms as sympathetic being the fight and flight response, and parasympathetic as the rest digest response. For those of you who've had a nice bowl of oatmeal or bagel and you're sitting here and my talk is lulling you into sleep, parasympathetic nervous system hopefully is not taking too much control. The problem with hypertension in 2015 is that in maybe 1015, our lives were a little bit different. We maybe had more of a fear in our morning commute of being chased by bears or wolves as we came to wherever it was that we're going. But for those of us sitting behind the wheel and listening to music or NPR, there's not many bears or wolves other than the people that may be reckless drivers behind us. So, our need for the sympathetic nervous system is a little bit out of kilter with what is required in our day-to-day life. Some of this is a subjective theory on my part, but clearly there's an imbalance in many of these patients, and this has been shown through many preclinical and clinical studies that there's a sympathetic imbalance and overdrive that is inappropriate for the patient's pathophysiologic needs. And this may in fact drive hypertension in a certain population of our patients. Now, the sympathetic nervous system has been well described by anatomists and physiologists over the years. And these fibers are rich and abundant and actually travel along the arterial supply chain of our vascular system in our body. And there's a rich arborization of these nerves from the aorta to the kidneys. This has been well described and used as a treatment goal for physicians as early as in the 1930s and 40s, when recognizing this sympathetic chain, surgeries were done. This trial was actually worked on by physicians in the Harvard system, where they actually went in surgically, tried to hack out these nerves, and the patients who underwent the surgery survived and recovered, had a tremendous benefit, not just in blood pressure control, but this is survival. Huge impact on survival, and these patients were followed for many years. The problem was that the surgery was very morbid, and it just fell out of favor because of the amount of side effects, because we had medications that developed through this pharmacological revolution over the past 20 years. But the idea behind the benefit in treating this aspect of our physiology didn't go away, but we have all these medications and they work in great ways, and the most significant impact, as work even here at our institution has shown, is that hypertension is driven by this RAAS axis. The production of Ang-1, its conversion to angiotensin-2, the upregulation of aldosterone secretion, all leading to this pathway of fluid retention and changes in our effective circulating volume, but also impacts on sympathetic nervous system activity, which can also then regulate and upregulate the RAAS axis itself. So we have all these medications that work in these different pathways, but despite this knowledge, as I had shown you earlier in the talk, we're still having trouble in getting blood pressure down in many of these patients. So thinking more granularly about the sympathetic nervous system itself, these nerves both travel from the brain to the kidney, but there's also a set of nerves that come back as a feedback loop from the kidney back to the brain. And if our blood pressure is high, we're seeing decreased renal blood flow, we get this signaling which then can affect how our brain is regulating blood flow and the basic physiology to multiple organs. And this has been theorized in some of the trials before this, that potentially this renal afferent system can affect varying disease processes as wide as diabetes and HFpEF. Again, a lot of this is theoretical, but has been described as a potential target which remains to be tested. Now, another aspect of the sympathetic nervous system that I'd like to hint on is the baroreceptors. So I've talked about the renal nervous system, but we also have carotid baroreceptors, which have a very sensitive relationship to blood pressure elevation. And all of us are taught this in medical school with the carotid massage technique, where we see both a slowing in heart rate and decrease in blood pressure. The way this works is much different than the renal system, which is more of a chemosensitive response. where this is fairly specifically related to the stretch response to these arteries. So going back to renal denervation as a potential target for therapy, fast forward from the 1930s to the early 2000s, and some physiologists and medical engineers said, well, we know this has been worked on in the past and seemed to affect patient outcomes. With current technology, can we go back to this and potentially get those same outcomes again? So some catheter-based systems were designed to actually impact and ablate the nerves that travel in the adventitia. These are the sympathetic, where the sympathetic nerves travel. And by removing the impact and activity of these nerves in patients with hyperactive, well, theoretically hyperactive sympathetic systems and elevated blood pressure, can we lower their blood pressure and potentially improve their health outcomes overall? And the thought of this is here seen in these cartoons, where if you can eliminate the sympathetic drive to the kidneys, well, then you may decrease the amount of excess RAAS stimulation that you get through upregulation of the sympathetic nervous system and reduce the amount of fluid retention that you get, but also impact the signaling going back to the brain and potentially the impact of that sympathetic upregulation to other organs in the body. Lots of excitement about this area of medicine, and eventually led to several trials which tried to show what this procedure did to patients when done clinically in humans. So the first study, SYMPLICITY HTN-1, used this catheter-based system using radiofrequency energy in the kidneys, fully percutaneous, and showed, this was just an observational trial of these patients, just a few in the US, but mostly in Australia and Europe, which had tremendous, this is outpatient blood pressure drops over many years as they were followed up in the long term. The initial data was 6-month data. And based on this signal, the SYMPLICITY HTN-2 trial was developed, which is a randomized controlled trial with patients with severe resistant hypertension, randomized, and many of you are probably very familiar with this data, to renal denervation in a control group, which were treated with what was described as best office practices. Patients were not blinded, but the patients who were randomized to renal denervation had a tremendous drop in their office blood pressures, over 30 points systolic, which generated a lot of interest, both in patients and providers and startup companies, to try to say, wow, this is exciting. Can I get a hold of this for myself, or can I get a hold of someone who can develop a way to treat this to make me a lot of money? And you know, the whole kind of genie was let out of the bottle, and this kind of race began to figure out whether this could work. And this data led to commercial clearance pretty much everywhere except here. And you go to meetings at that time, and you almost kind of felt like providers were laughing at you, saying, "Oh, well, you're silly FDA. You know, they're holding you back, but you know, we've reached the next level of hypertension therapy." And we kind of skittered back to our corners and hoped that maybe that would change for us if this truly worked. But there were a lot of hypotheticals in the way these trials were designed. And SYMPLICITY HTN-3 was designed to be the definitive answer as to whether this would work, but really was looked at more as just a pathway to commercial clearance, because everyone was very confident based on OUS data that this worked, and we just had to get through the bureaucratic hurdles so that this could be provided at fairly much every medical center around the country that was interested in this. So this, I'm going to kind of go through a little bit more detail how HTN-3 was designed as far as a trial. So it was much more rigorous than the European and OUS trials. It was a 2-to-1 randomization that was blinded, with all the patients going through a procedure, no matter what their assignment was. So patients in our cath lab had headphones, were listening to Motown music, were blindfolded, were very heavily sedated, and had no idea, for the most part, of what had happened to them. And we followed them for 6 months. They had to go through a screening process, which at the time was felt to be rigorous. They had to have office blood pressures over 160. And you really had to find very hypertensive patients, had to be on at least a maximum dosage of at least 3 medications, one of which had to be a diuretic. You watched them for 2 weeks. If their blood pressure somehow dropped during that initial 2-week phase, they were eliminated from the trial. This included 24-hour ambulatory data, as I described earlier in the talk, which is much more powerful in terms of predicting patients with a higher burden. And then we followed them for 6 months, and then at 6 months we had this grand opening of the envelope where patients could find out what they really got, and if their blood pressure was still high, they then had the option to get therapy in the crossover group. So one of the primary endpoints of this trial was safety, and the data shows that this can be done very, very safely. There's no question about that in the way that this was carried out in the HTN-3 trial. The performance goal set for the trial was 9.8%. There was a statistically significant difference from that in what actually happened in the trial at 1.4%, and this included everything. Creatinine clearance decrease, vascular complications, anything that could have potentially happened during the course of the trial. And from a renal standpoint, there was no change in renal function. Cystatin C levels were measured. There's really no impact, or adverse impact, I should say, on renal function across the board through the course of the trial. The main events that happened were typically related to a failure of a closure device or some bleeding issues, as you would see with a catheter-based procedure overall, and no significant difference between the sham procedure group and the treatment group. But the money was in the primary efficacy endpoint, and this was a drop in blood pressure in the outpatient group at 6 months. And the trial had been statistically designed with a 5 millimeter superiority margin to be the threshold beyond which it would be declared a success. And renal denervation dropped blood pressure by 14 points. Well, that's pretty good in terms of what we see as a blood pressure drop and what we put patients on in pharmaceutical trials. But then you look at the next bar in our control group, and their blood pressure dropped almost 12 points, which is also pretty good for pharmaceutical trials, which gives us a very measly drop in blood pressure of only 2.39, which is well below the primary cut point which had been defined. And this was a shock, and almost like the SPRINT trial was announced early before it was published, these results were announced early before it was published. I think from their PR departments as a way to maybe diffuse the shock of what would have happened if this was shown at a medical meeting. I think they were trying to kind of delay the impact of how much people were expecting this to be a positive trial. Now, ambulatory blood pressure monitor was also included in all patients as a secondary endpoint, and the drop in the treatment group by itself was pretty good for a ABPM result over 6 points, but again, almost 5 points with just a less than 2 point difference between groups, and again, nowhere near anything that would be considered clinically significant. Now, these patients have been followed up over time, even the patients who were in the control group that went through crossover 6 months later, and the patients who were initially in the placebo group who underwent denervation had a fairly good drop in their blood pressure of 17 points. But when you look at the patients who had received renal denervation in the first place, their blood pressure stayed low at 1 year. So many people hoped, well, if the blood pressure goes down, the control group, maybe whatever placebo effect that they were having would go away, and we can show that this is a positive trial in the long term. The problem is that hasn't happened so far. So out to 12 months in the non-crossover patients, at 6 months, blood pressure had dropped quite a bit, but following them out to 12 months, the blood pressure drop, although it has mitigated somewhat, it still is a 21-point drop from baseline, which eliminates the possibility of any significant difference between this group and the patients in the treatment group out to 12 months. So the placebo effect, or whatever effect has taken place in this patient in the control arm, still has persisted at least out to 12 months. And this is the same story for ambulatory blood pressure monitor data. Again, denervation, it's persisted. Crossover patients, that underwent denervation had a drop in their blood pressure. But in the non-crossover patients, you still see some lowering from what happened at baseline. So this really was sort of a sad story for many of the patients and physicians involved with this trial, myself included. There's a lot of hope in this as to this being this, revolution in how to lower blood pressure. So what went wrong? Was this the greatest manifestation of the placebo effect ever done? Or is there potentially more to the story? And this is where I'm going to kind of make an argument on both sides and kind of leave the decision up to you as to what to think moving forward from this talk. So one thing that was interesting in the HTN-3 experience was the initial trial involved 60 centers, and the protocol was written in a way where the enrollment criteria was so strict as far as the medication criteria was concerned that enrollment was really going at a snail's pace. And a lot of folks, myself included, gave feedback to the sponsors and the steering committee that the way they had written the protocol was really unrealistic in terms of actually being able to find patients that would meet these criteria. So they loosened it up a little bit in terms of what the medication requirements had to be, but they also enrolled a lot, they included a lot more trial sites, taking it from 60 to 90 centers. And enrollment picked up pretty well after that. But the problem was that the majority of these procedures that were performed by folks that had very little experience in doing the procedure. So over half of the interventionalists that did a procedure in this trial had done 2 or less denervations. Typically, in trials of a new technology, usually will involve 1 or 2 roll-in procedures. We do this with transcatheter valve trials and lots of new coronary device trials where you might want to, do the procedure once or twice, get the bugs out, and then the next patients can be included with the statistical analysis. But that was not done in this trial. There was no formal, simulation or animal lab training for the operators. Basically, patients showed up, they met criteria. The proctors came from Europe. A little bit to the Europeans' fault, I would say, in that they were going around saying how easy this was. And now they're going around saying the opposite thing. They're saying, well, this is a very complex procedure. You Americans really didn't know what you were doing. But there were a few centers that did a lot. Now, we were included. Emory was right here in the top group in terms of procedural experience. But this is sort of the European story, and the outside US story was where they're saying, well, we have this global registry, and over 60% of our interventionalists have done at least 15 of these procedures. So we know what we're doing, so that whatever blood pressure drops you see in our data is real, whereas the blood pressure drops in your data probably reflects the fact that you didn't know what you were doing. Now, I don't know if that's true or not, but this is the argument that's being made by some of the folks across the sea and other shores. So these folks in their registries will say, well, if you look at the patients who would have met HTN3 criteria in our registry, well, their blood pressure has dropped 22 points out to 12 months. But again, 12 months and 21 points compared to what? There's no placebo group, there's no sham group in this registry. So my argument would be that I don't really take anything from this data because it pretty much sets up the same story as what we had seen in the initial Symplicity HTN1 and 2 trials. But there's this voice, of argument that continues to come from many sides to say that the folks who did these initial trials knew what they were doing and that their data is relevant, whereas ours is not. And I would argue that's probably not the case. Now, an interesting thing about the HTN3 trial, which no data like this has been published from HTN1 or 2, and this was a sub-study that I and Janice Lee in nephrology were involved with and published in European the ESC journal, looked at all the denervations that were done and tried to stratify them in terms of how many patients actually received denervation in all the places that you were set out to try to do it. So the goal of this therapy was to do ablations in a circumferential pattern throughout the length of the renal artery to try to get all the renal nerves as they course around the renal artery. And what we found was that a large number of patients didn't receive a full 4-quadrant ablation. So if you look at the total number of patients, 253 of these patients didn't receive a full 4-quadrant ablation. 68 of them had one kidney that probably received 4 quadrants, but not the other one. And a small proportion of patients actually had full 4-quadrant ablations done in both kidneys. But when you look at the blood pressure data split between these groups, the patients who received denervation as it was intended to have been delivered actually had a much lower drop in blood pressure, both in office and in ambulatory blood pressure monitors, than the groups that did not receive a full denervation. So the concept has been raised of whether there's a dose effect in this. And we experienced a little bit of this in the trial, because as soon as the patient had a deep inspiration and the catheter moved during treatment, if it had gone beyond the initial 30 seconds, you were told to stop the denervation and move on to the next site. You could not complete the denervation. And we were not allowed to go into any larger branches beyond the first main trunk of the kidney, even if it was an enormous branch, just in the way the protocol was designed. So there was some criticism of this trial that these patients may have come in, they may have had horrible blood pressure, but they may have received a therapy that was underdosed for what could have been achieved with the catheter-based system. Again, this is theoretical and it's all sub-study data after the fact, but the numbers are interesting and thought-provoking. So I'm going to kind of go through some other confounding factors in the way that this trial was designed, and again, just to kind of play devil's advocate of maybe ways that the trial had some issues in how it was designed and implemented. So the main thing that identified these patients was the medications that they were on. And after the fact, it turns out that there was a lot of variability in how patients were taking their medicines once the trial was reported. The goal was that patients would be on at least 3 meds. They would be on those meds for the entire course of the trial, but there were no pill counts that were done. There was no measurement of compliance with urinary byproducts. And it turns out that a lot of patients ended up changing their medicines during the course of the 6 months until primary endpoint was measured. Now, how drugs and denervation impact each other, we don't know, but when the drugs are a moving target, it's hard to know what the denervation really does. And that, unfortunately, is a problem with this trial, for better or for worse. So a way to think about how to do this in the future is to do one of 2 things. One is to take patients with a hypertension and just get them off all their medicines. Then there's no more room for confounding. And many of you may say, well, how can you do that? Well, make an argument that you actually can in some patients. Or you take full control of the medicines. You dictate to the patients what they're on, and not only tell them what they're going to be on, you also measure in some way that they're actually taking the things that they're supposed to be on. And that way, eliminate any possibility of blood pressure adjustments or variation because of problems in medication compliance. So in HTN-3, 40% of patients had some type of change from the baseline, from their entrance in the trial, to the point that their blood pressure was measured 6 months later. And most of these med changes were medically necessary. I don't even know who these 30% of patients were where it was medically unnecessary. That doesn't even make sense to me. But how that happened in the trial, I don't know, but it somehow did. To our site's credit, we only had 1 patient that had a med change, and that was because the blood pressure had dropped significantly after denervation. But it turns out there are a lot of issues with that patient's psychosocial status, so there's not even a question whether that patient's data was relevant. But whatever it was, most of these patients had a med change due to some adverse event. Either the blood pressure suddenly went higher during the course of the trial to a point where it was unsafe to not make a change, or the blood pressure dropped after denervation and had to be changed. But whatever it was, 40% med change greatly impacts your ability to assess the treatment effect. So in the midst of this general dysthymia in the interventional community that was involved with this, a group in Europe said, look, we're looking at our HTN-1 and 2 trial. We recognize there's limitations. We see what happened in HTN-3. Maybe we can do this in a way that's a little bit different. So they took this concept of taking full control of patients' medical therapy, similar patients to HTN-3, but took them off their meds and then changed their medications to a set regimen of a diuretic, ACE-ARB, and a calcium channel blocker. Watched them for a while to make sure that they were stable. These patients had measurements of compliance, and then were randomized in a similar fashion in HTN-3 between denervation and this stepped hypertensive therapy. And then over the course of the 6 months, if blood pressure adjustments had to be made in either group, the adjustments were carried out with a very strict regimen of how it could be done. And patients could first be put on spironolactone, then with bisoprolol, then with prazosin. And all of this had to be done in similar fashion at all sites. So it was much more uniform in both the control group and the treatment group. An ambulatory blood pressure monitor was the only outcome that was measured as far as blood pressure is concerned. So the primary endpoint, and this is both daytime and nighttime ambulatory blood pressure results, there was a clinically significant drop in ABPM levels of just about 6 points, both daytime and nighttime, in patients who underwent denervation as compared to control. And drops of 6 points in an ambulatory blood pressure monitor is pretty darn good from a standpoint of blood pressure trial endpoints. So this trial raised a lot of questions and said, well, maybe HTN3 really did have some problems, and maybe there is something to this that needs to be further addressed in a way that is better designed as far as the trial is concerned. Now, the whole concept of taking patients off their medications that I had mentioned is something that's been looked at and been done before. So as drugs have been developed over the past several decades, in the early phase of clinical trial development for these pharmaceutical agents, many times in the early phases, patients with a lower intensity of hypertension are taken off their medicines and observed on these newer agents. And there's meta-analysis data that show that patients who are taken off their medications, when you compare them to the placebo group, where they're not taken off their medicines, I should say, sorry, there's really no difference in events. And this is, of course, over a short-term period. You can't really do this over the long term, but generally, if you're just talking about 2 or 3 months, you can do this in a way where you take out the confounding of the medicines and just look at the effect of your investigational agent. So potentially, this is a way to assess newer device therapy for hypertension. Now, from the standpoint of the study population, there's some very interesting signals that come out when you kind of dissect out the data. So these patients were what I call unicorns. We can describe them on paper, but to find them is very challenging, and whether they truly exist is another issue altogether. So these patients were on an average of 5 medicines, including a diuretic at maximum dosages. This is a USA-only study. Had the largest African American cohort or patients of African descent compared to any other denervation trial done up to that time, and patients were very obese in general with a very high BMI. Now, it turns out there's a lot of variability based on blood pressure response based on who these patients were. So an alternative in how to better design these trials is to say, well, let's be much more strict in our enrollment criteria and be much more focused on ambulatory blood pressure monitor data as opposed to outpatient cuff data. And then try to standardize how medications are delivered through the trial. And the reason for this is if you take the patients and dissect out patients based on their underlying ethnicity, there's an interesting signal that emerges. So the Europeans really kind of grabbed onto this sub-study and said, well, if you take the patients who were not of African descent in the HTN3 trial, the blood pressure drop between treatment and control reaches statistical significance. Now again, this is a small cohort of the larger trial. This was not statistically powered for that. But in the African American cohort, the blood pressure drop was actually better in the sham procedure group. So the reason then is, well, why is this? When you look at these patients, the medication regimen that they were on was actually very different at baseline than the medication regimen that patients of a non-African American descent were on. There was a lot more use of vasodilators in this group, which has to be taken often at least 2, but more commonly 3 times a day. And TID medications in general are very challenging for anybody to take. But once, and this has been well described, when anybody enters a clinical trial, the way you address your overall health activity is very different before the trial compared to after the trial. Because in a trial, now you have a certain level of expectation on yourself, because you've signed this consent form, you've been described this grand purpose of the trial, and it potentially gives you a little bit of a different motivation in terms of how you carry out your overall health activity and taking medicines. And also, there's this higher level of overall monitoring. You have these nice research nurses and research assistants who are calling you on a regular basis saying, Mr. and Mrs. Jones, how's it going? And just that simple activity has been definitely shown in clinical trials before to make a difference in how patients behave and the effect that has on the outcome that you're measuring. And this is what potentially happened in HTN3 in the control population. As far as this whole concept of the unicorn, this was data that we published looking at patients presenting to our clinics at Emory Midtown with a diagnosis of hypertension, or cardiology clinics. And we stratified them based on their definition of resistant hypertension. We used the AHA consensus statement, and when you look at that, 31% of patients in our clinic met the consensus definition of resistant hypertension. But then when you add a diuretic as a mandate, and then add a mandate that all the medicines have to be at maximum dosages, and then include diuretics, and then get to all of the inclusion-exclusion criteria of the renal denervation trial of HTN-3, less than 1% of patients would have met the criteria to enter the HTN-3 trial, which is not terribly relevant compared to all of these 31% of people who had what was described as resistant hypertension. So you could ask the question of whether HTN-3 is at all generalizable to the overall hypertensive population that we're seeing in our clinics. So the thought is, well, maybe we should move from this very severe risk group of hypertension to a more mild to moderate risk group of hypertension in terms of who this potential therapy is applicable to. That's what's being at least discussed out there, because it may make a much higher impact in terms of cardiovascular outcomes in patients. Plus, the patients in this very high-risk group may have such a unique pathophysiology underlying their hypertension that they may not respond to anything that you throw at them, whether it's 6 medications, renal denervation, or some type of new thermonuclear response to lower blood pressure. So just to kind of show you how this was done, the first generation Symplicity Flex catheter was a single lead electrode catheter. And we, on a 2-dimensional X-ray image, had to give ourselves at least 5 millimeters buffer from the bifurcation and deliver this spiral pattern in what we think is 3 dimensions around the course of the renal artery. So this is a distal treatment. You come back 5 millimeters. I'm assuming this is somewhat more lateral. Come back even further. Come back again further 5 millimeters, and then we were always told to really point to the superior aspect of the ostium, because the very limited anatomic data suggested that most of the bang for your buck was there as far as the renal nerves are concerned. Now, whether I was in a full 360-degree arc there, as it is with your guess and my guess, we can only assume, but there's really a very difficult it's very difficult, in our ability to judge whether we were anterior or posterior based on how the catheter behaved in the body. So this has led to a thought of, can we improve the way the procedure is done? Because of this sense of whether there was potentially an incomplete denervation and some dose response from an under-treatment of patients. So this has led to a second-generation catheter with multiple electrodes, which takes some of the guesswork out and places these electrodes in a full 360-degree arc around the catheter, with all of these electrodes spaced 5 millimeters apart. And can we potentially allow treatment beyond the main trunk into the bifurcation? There's been European data looking at bifurcation treatment showing that it has been safe and effective, and try to involve, at least in the initial phase, a smaller group of interventionalists, make sure that they're well trained before you actually go in and do the procedure. And this was a very different approach than what was done in HTN-3. So this new catheter, at least one that we're going to be testing here at Emory, is the spiral catheter, multi-electrode. It's a much shorter treatment time. Each treatment with a single lead electrode was 60 seconds on its own. It's 120 seconds. But this would be 60 seconds for all 4 at the same time. And there can be some pain viscerally associated with the delivery of the treatment, but if you can shorten this down to 60 seconds for all 4 and potentially deliver more treatments, then potentially you're going to greatly impact the concept of dose response. Now, this is also being looked at in multiple other devices. There's still very great interest in this field. There's another trial ongoing looking at multiple electrodes but based on a balloon system. There's an ultrasound system which has not yet started phase 3 trial here in the US, which delivers concentric ultrasound. There's a first-in-man trial in progress for a catheter that actually delivers these fine microneedles to deliver ethanol around the renal artery. So a lot of interest in how to potentially do this better to kind of get over some of the limitations that HTN-3 may have had. And we're pushed to do this also because we now have new anatomic data, which was just published in the last year from Ranu Vermani's group with CV Path, which looked at postmortems in patients and renal nerve anatomy. And what we now know is that this whole concept that the renal nerves should all be targeted more proximally is actually potentially bunk. And what we find is that the renal nerves proximally are actually much farther away, and they're much more uniform and distributed evenly closer to the distal aspect of the renal artery distally. And this is in complete opposite fashion of what we were instructed to do in the HTN-3 trial. And this is greatly impacting how current trials are being developed. So when you look at preclinical data where the main renal artery as well as the branches are both treated, there's a very tight data point here where the blood pressure is more consistently dropped as measured by norepinephrine levels. Now the Symplicity spiral catheter has gone through its first-in-man experience, and again, this is observational data, but blood pressure has lowered compared to the control group by 20 points, and this at least is setting the stage for a next second generation of trial. So again, where are the ways we can go better than what was done in HTN-3? Well, with medications, try to standardize the medicines, maybe obtain data off of medications, be more consistent in assessing for noncompliance. As far as our study population, try to go for a more moderate hypertensive group, focus on ambulatory blood pressure monitor, and really try to get patients from across the world in a uniform fashion, and try to do better in terms of how the procedure is done. So this has led to the HTN Spiral program, which is including 2 parallel sites. There's only 20 sites globally. Emory is one of them. And this has 2 flavors, the off-med trial and the on-med trial. And I'll go into both of these in detail. So the off-med study is looking at patients that are much more to the upper left in that risk matrix of hypertension. Looking at patients first with an office-based blood pressure and describing the philosophy of the trial, and then taking them off their medications, and then watching them very closely with safety checks over at least a month-long period. And if at any time their blood pressure goes over 180, they are automatically out. They cannot work or game the system. From a safety standpoint, we cannot tolerate any potential safety issues, so those patients will be excluded. But for those patients who have an earlier manifestation of blood pressure or have hypertension but just are not tolerating medicines despite their best efforts, as long as their blood pressure is less than 180 and it's consistent throughout that phase through the screening process with an ABPM between 140 to 170, they can potentially qualify for this trial. And again, it's going to be between renal denervation and a sham procedure. The patients won't know what they got. But the follow-up is shorter, and it's very carefully observed. Every 2 weeks, these patients have to come in with blood pressure monitoring. There's a strict guideline in terms of how medications can be re-administered once their follow-up primary endpoint is obtained at 3 months, if they need to be put back on their medications. So this should really be a definitive trial in looking at the effects of denervation without these other confounders in the background. The on-med trial is a little bit different at a more moderate risk hypertensive group, looking at patients with blood pressure between 150 and 180, monitoring for compliance, and they can only be on these 3 medicines: thiazide, calcium channel blocker, and an ACE-ARB at least 50% of the dosage. No more, no less. They have to be on those 3 meds alone to qualify. And they are going to be monitored with urinalyses for byproducts metabolically of these medicines. Blood pressure has to be between 140 and 170 on ambulatory blood pressure monitor, and again between treatment and a sham procedure, and they'll be monitored out to 6 months with drug testing throughout that phase. So much more rigorous, but looking at a much more generalizable patient population. So I want to also take a little bit of a different tack and tell you about a trial that's been going on for a while here, which does address those potential unicorns or near unicorn patients with blood pressure. And again, going back to the baroreceptor, the way that baroreceptors work is again with these nerves in the adventitia, which is very thick and is much more sensitive to stretch perturbation. Nervous signal goes back to the nucleus solitarius, but it's pretty much with a sustained activation of pulsatile stretch stimulation through the baroreceptors, and this leads to increased parasympathetic signaling, a decrease in sympathetic signaling, and thus relates to our decrease in heart rate and lowering of blood pressure that we see when we do a carotid massage. And we know this can be done from a catheter-based standpoint, because when we do carotid stenting, you will see a blood pressure drop very commonly, but oftentimes a blood pressure drop goes away after a few days to a couple weeks. So an engineer and medical device innovator said, well, maybe we can take advantage of this relationship of baroreceptor stretch, but design a device that specifically, its only goal is to maintain this increased pulsatile signal in the carotids. Well, does this work therapeutically? We do know it works because there was a trial that looked at an external electrical generator delivering energy to the carotid arteries, which lowered blood pressure, but had some safety issues with the morbidity of the procedure that was involved. So this is the device. It's called a Mobius HD. It has several different sizes based on carotid anatomy. Is supposed to answer this question. So if we can increase the overall strain as measured here mathematically by increasing the radius of the carotid artery, then you'll increase the amount of stretch that's sensed, because what we're doing with this device is essentially putting a square peg in a round hole. And the modulus or effective radius between the posts of these devices simulates what the vessel would be as if you had stretched it out this wide. When you put a carotid stent in, the stents are the same radius within the vessel, and you have a very little change in the overall strain on the vessel, and it's not pulsatile. But this device gives you theoretically a pulsatile change, but one with a much more dramatic impact on what the baroreceptor nerves are sensing as a change in strain. The technology is all based on carotid deployment equipment, which has been around for almost 20 years now, and has been proven to be a procedure that we can do safely. And this is how we do it. You're trying to get after these nerves, put this device right at the carotid body, and increase the stimulation of the carotid sinus nerve back to the brain. So we're proud to say that this was actually done first in human here at Emory, which many folks don't know about because the trial hasn't been finalized yet. But we were the first in the world to do this, and was actually a very reasonable, approachable procedure. There was nothing dramatic about it. You can see the device here, and this is where it was, right here in the carotid body. And again, the impact here is to try to increase the signaling of these carotid sinus nerves. So this is part of the CALM trial, which is still ongoing throughout the US and in Europe. Basically is almost identical to the HTN-3 trial, with the exception that we have very careful screening of carotid and aortic disease. Any disease automatically excludes the patients. Again, site of our first-in-man case. And this trial has really been now driven by the European sites, because since HTN-3, a lot of the interest in this area has really kind of gone to the wayside, and it's been a little bit harder to convince cynical practitioners that there's some role still left for these type of trials. But these patients that went through this procedure was done very safely, and I just want to get to this data very quickly. They've had very dramatic drops in their blood pressure, and also with ambulatory blood pressure monitoring, which has been included. And now we've got several patients that have now made it out, 5 patients out to at least a year's worth of data. And the endpoint I want to kind of point out here is that at least 8 patients so far of the 18 have had to have their medications changed because their blood pressure has dropped so profoundly. That type of impact was not seen in HTN-3. And these blood pressure drops that I'm showing you are in the setting of medications being taken off. So a pretty dramatic effect, again, in a very select group of patients. But if these patients are out there, there's still some potential reason, I think, to study this. So we know the sympathetic nervous system is part of the underlying pathophysiology of hypertension, and HTN-3 was an imperfect trial. I'm not arguing that renal denervation works, but I'm arguing that we still need to find out if it works. Because if it does work, now with the potential message from the SPRINT trial, can we afford not to find out? So the Spiral HTN program may be the definitive answer of whether renal denervation works. If blood pressure is not lowered after Spiral, I would guess that this whole area of interest may be dead in the water, at least from the renal sympathetic denervation standpoint. I would also argue that carotid barostimulation, for those of you who have patients with horribly severe hypertension on at least 3 medicines, may have a role to play in these very rare patients with severe refractory hypertension. We've been able to do it, and we've done it safely here and throughout the world. And again, can we afford not to further study these technologies if there is some method to the madness here? So with that, I'll end and be happy to take questions. Sorry, I went a couple minutes over, and this is just our contact information for those of you who may be interested to refer patients for trials. Thank you for your interest.
Thanks, Chandan. Really appreciate that. It was very good and a great overview. I think given the hour, we'll probably just do questions offline. If anybody has anything, they can chat with you. We'll try to be respectful of everyone's times. But thanks so much, everyone. We'll see you back Friday morning.
The preceding program is copyrighted by Emory University.